Okay, we're going to continue on the urinary system. This is actually a really good little comic of the nephron. And once we've gone through this piece here, you might want to come back to this and kind of walk yourself through this, and it will make a little bit more sense to you. So we've gone through the anatomy, and now we're going to talk about how we do what we do in the kidneys, which is basically the formation of urine. Now we know that urine is a byproduct of maintaining homeostasis. So we don't make urine just to make urine. We make urine to maintain homeostasis. It's a way to remove things from the body that don't need to be there. So this all starts in the blood. We filter the blood, we process the blood, and then whatever gets pulled out and does not get pulled back in is going to end up in the urine. Okay, so the kidneys are processing a huge amount of blood. Remember that the renal arteries branch directly off of the abdominal aorta. So you have a significant blood supply coming in, and then you have a huge branching that occurs. And so the glomeruli are dealing with over a liter of blood every minute. So that's a significant amount of blood that's moving into the kidneys. You're going to make somewhere in the neighborhood of about 180 liters of filtrate a day. So the movement of fluids and solutes from the blood into the tubule, that's filtrate, and you're going to make about 180 liters of it. You don't have anywhere near 180 liters of fluid in your body total. You're going to concentrate that filtrate down and to somewhere in the neighborhood of, we'll call it 1 to 3 liters, and a very small amount of what gets filtered is going to end up in the urine and actually leaving the body. So when we talk about the formation of urine, we're wanting to filter blood, reabsorb all the good stuff that we got rid of, and get rid of all the bad stuff. There's basically 3 components that are going to be happening all the time. We've got glomerular filtration, where we are going to filter out. We're going to find out not very specific at all. So if you fit, you filter. That's the issue. If you fit, you filter. So there's going to be a lot of good stuff that gets filtered out with the bad. So the second process that we have to get into then is tubular reabsorption, moving from the tubule back into the blood. All the good stuff that filtered out needs to move back into the blood. The other process goes in the opposite direction. Tubular secretion goes from the blood back into the nephron. And you might be wondering why both filtration and secretion are going in the same direction. We will find out filtration is very non-specific, whereas secretion is highly specific. Now, the fourth process here is water conservation, and this is kind of a separate process that we're going to deal with in another video, but it's going to happen after all of these other things. So we're going to focus on these 3 for now. Starting with filtration. So this is passive. We're relying on hydrostatic pressure of the blood to force anything that can fit through the membrane through the membrane. So this filtration membrane is very reminiscent of that respiratory membrane we talked about in the lungs. So here we've got the fenestrated epithelium of the capillaries. So we've got the endothelial cells that are going to be fenestrated. They've got the pores, the basement membrane, and then the feet processes of the podocytes, which, if you remember, are the visceral layer of the capsule. So when you add all that together, you've got your fenestrated epithelium, the basement membrane, and then you've got the podocytes, so the little feet processes. So to get through, to filter, you have to be able to get through all of this. Here's another really nice view of the fenestrations in the capillary, plus all of these podocytes and their little processes coming off of them, wrapping around the capillaries. Essentially, anything smaller than about 3 nanometers passes freely. Anything larger than 5 is barred. So we should not filter out blood cells. We should not filter out plasma proteins. So here we can see this is our afferent arteriole coming in, the loops of capillaries, and then the efferent arteriole coming out. We're going to filter out into the capsule, which is then continuous with the proximal convoluted tubule. So by the time the blood gets to the afferent arteriole, it's got about 60 millimeters of mercury worth of pressure left. So remember that pressure is directly related to the left ventricle. So the left ventricle applies the pressure, and by the time it gets down to the kidneys, which is not that far, keep that in mind, it's down to about 60. So that's one of our pressures, and is going to be a pressure that pushes out. So hydrostatic pressure is going to push things out into the capsule, driving filtration. Now, we also have two competing pressures. We have the colloid osmotic pressure of the blood, so the albumin's drawing back in, it's about 32. And then, because we're constantly pushing fluid out into this space, this capsular pressure begins to push in. So the more fluid is out here, the more that fluid pushes in on the capillaries. So when we add it all up, we end up with a net filtration pressure of about 10. So we're going to push out at about 10. Okay. So it's imperative that we maintain this filtration here. This is how we get rid of all the waste products in our blood. If for some reason we can't exceed these pressures here, then filtration is going to stop, and that's going to put us in a really bad place. Also make a note, anatomically, we have a large afferent arteriole and a small efferent arteriole. So there's a huge amount of blood coming in, and then it has to wind itself through these capillaries, and then the outlet is more narrow than the inlet. So this also helps drive pressure in here. So even anatomically, we are designed to make sure that we maintain high pressure to maintain filtration. So GFR, or the glomerular filtration rate, is basically the volume of filtrate that we are forming per minute. It's usually somewhere between 120 to 125 mils. So GFR depends directly on three things. Number one, that net filtration pressure. So it has to be above the pressures that are pulling in. The surface area available. So we have lots of glomeruli, and that gives us a huge amount of surface area, again, reminiscent of our lungs, and how permeable that filtration membrane is. So if something were to increase the permeability, then we would begin to see higher GFRs. If something was to decrease the permeability, we would see lower. So again, all of this is very, very similar to what we talked about in the lungs. GFR is very tightly regulated in terms of maintaining homeostasis and its role in systemic blood pressure. So generally, we don't see big swings in GFR. There's two ways to control it. So the first are what are called intrinsic controls or auto-regulation. Auto means self. So this means the kidney regulates the kidney. There are two mechanisms under intrinsic controls, something called myogenic and then the tubuloglomerular feedback mechanism. They alone, so the kidney alone, can maintain stable GFR when our mean arterial pressure is anywhere between 90 and 180 millimeters of mercury. So if our systolic pressures are between 90 and 180, GFR remains stable. That is amazing. So no matter what's happening with systemic blood pressure, it can drop down to 90 or go all the way up to 180, GFR doesn't change. That's just incredible. I'm going to tell you why intrinsic controls are really, really important. Everyone has had, probably at least once a day or once a week, okay, a moment where your blood pressure spikes. Maybe it's because you're walking and trying to text and you like almost fall off the curb, or you lean back too far in your chair and you feel like you're going to fall over, and you get that momentary spike of blood pressure, that sympathetic nervous response. That little blip, that tiny little blip of a skyrocketing blood pressure for, less than a minute, a few seconds usually. If intrinsic controls didn't exist, that blip would produce somewhere in the neighborhood of 35 liters of urine. That's gigantic. So we can have those crazy little blips where our blood pressure goes really high and GFR remains stable. So therein lies the beauty of autoregulation. Now, we also have extrinsic controls, which you'll be happy to know we've already talked about, the nervous and the endocrine systems. They are going to activate when blood pressure falls somewhere below 80. So when systolic falls below 80, we're in danger of not being able to drive filtration at all. But more importantly, our blood pressure has dropped below 80. So we've got other things we need to worry about. So let's get into these controls. So we talked about before how our body is far more concerned with a drop in blood pressure than an increase. So we're going to focus on the what happens when we drop blood pressure. So these two lines over here, the blue and the tan, they are intrinsic controls. These two over here are endocrine and nervous system. So these are extrinsic controls. So let's deal with these first. So the first is what's called the myogenic mechanism. Myo means muscle, so this must have something to do with muscle. So as systemic blood pressure drops, there is a decrease in blood pressure in that afferent arterial, which means that GFR is going to want to go down. Now, as blood pressure drops in the afferent arterial, the stretch in the smooth muscle in the walls is going to decrease. So instead of being stretched out really nicely by a good blood pressure, it's just getting barely touched. That is going to trigger vasodilation of the afferent arterioles. So all the way across the kidneys, all of the afferent arterioles are going to vasodilate. So we already know that the afferent arteriole is bigger than the efferent. When it vasodilates, it gets even bigger. What we're doing here is we are compensating for the lack of pressure by increasing the volume that's moving into the glomerulus. The kidney itself cannot change blood pressure. It cannot directly talk to the heart and change blood pressure. But intrinsic controls are designed to maintain GFR despite blood pressure. So we vasodilate the afferent arteriole, and that is going to increase the volume, okay? And we know as volume goes up, pressure goes up, GFR is going to increase to its normal range, and we have done our job. We have maintained GFR. Now, the tubuloglomerular mechanism here is going to rely on those macula densa cells. So as GFR decreases, so systemic blood pressure drops, GFR drops, filtrate flow is going to slow down significantly, and we're going to see that decrease in sodium chloride in that ascending limb. So this is where the juxtaglomerular apparatus or complex comes in. So those macula densa cells are going to go, whoa, I don't have enough sodium chloride, so we are going to release vasoactive chemicals. That is going to vasodilate the afferent arterioles, which in the mechanism we just talked about would increase GFR. Now, these two generally are going to happen together. Okay, so there's going to be like sort of a double hit on these afferent arterioles. So you've got a myogenic mechanism, and then you also have a vasoactive chemical that is going to be inhibited, so you're not going to be able to vasoconstrict, which is going to allow vasodilation, and boom, we get increased GFR. Now, the only thing these two are concerned with is maintaining GFR. They actually don't care about systemic blood pressure at all. Their job is to maintain GFR. Now, as this step is occurring, we are also going to come over here and talk to those granular cells and tell them to release renin if GFR begins to drop and drop and drop and drop and drop, where we start seeing that we're below 80. We're going to activate the renin-angiotensin-aldosterone system. And we're also going to have sympathetic nervous response that is going to activate the granular cells and vasoconstrict. All of this is going to lead to an increase in systemic blood pressure through mechanisms that we've already discussed. So extrinsic mechanisms do not care about GFR. Their job is to increase systemic blood pressure, which will in turn increase GFR. Intrinsic mechanisms don't care about systemic blood pressure. Their job is just to maintain GFR. So you want to go through these mechanisms and make sure that you can put them together and understand what's going on. If you are a little sketchy on the RAS system, go back to the cardiovascular stuff. Like I said, it's just going to keep coming back over and over and over again. So once we've filtered, which is a very inexact method of doing anything, filtration relies solely on pressure and a semi-permeable membrane, and if you fit, you filter. We're going to get rid of a lot of the stuff that we need in the body. Water, glucose, amino acids, vitamins, just tons of ions, and we need that stuff back. So after we get into, or after we're done with filtration, we're going to jump into tubular reabsorption. So you lose your entire plasma volume about every 22 minutes. So about every 20 minutes, your entire volume has filtered out. Obviously, that volume has got to be returned to the blood, or we would have a zero blood pressure. And obviously, we know that that is, dead. So we don't want that to happen. So reabsorption is the process of moving this stuff back into the blood. So good functioning healthy kidneys, we should get back pretty much all of our organic nutrients, so glucose, things like that. We should reabsorb water and ions based on the physiological needs of the body at the time. We're going to use active transport, we're going to use passive transport. There's a whole bunch of things going on here in the proximal convoluted tubules. So the most important step of all is going to be active transport of sodium. This is where we use our ATP. This is where the PCT is using all of those mitochondria and just driving this process of getting this stuff back. And we're going to start by moving sodium. Actively transporting sodium allows us to then passively transport other things like water and chloride, and then co-transport many other things like amino acids, glucose, things like that. So we use sodium as kind of our primary, but that's going to help drive all the other transports. Water moves via osmosis through aquaporins. We have something called the obligatory water reabsorption. This is the amount of water that has to be returned to the body no matter what. So there is a certain amount that will be reabsorbed no matter what the physiological conditions are. After that, after we've hit our obligatory reabsorption level, then it becomes based on the body. Are we dehydrated? Well, we better reabsorb more water. Are we overhydrated? We better pee out more water. Okay, so once you've hit your obligatory, then it becomes physiologically based how much it's going to move. Now, any solutes that use a transporter are going to have what's called a transport maximum, or essentially the point at which the transporters become saturated. So here we can see glucose. So we start with glucose in the blood, which is going to get transported. It's going to get filtered out into the filtrate. And then we've got glucose transporters that should be able to reabsorb all 100% of our glucose. So our urine does not contain glucose under normal circumstances. If, however, your starting blood glucose is above 180, then what happens is you filter all of it out into the filtrate, and the filtrate moves through here, and all of your transporters are busy. They are literally transporting glucose, and all of this glucose passes right by, because remember that this filtrate is moving. It's not going to sit and wait for the next transporter to open. It's just going to keep moving. So we end up with glucose in the urine. Anything above about 180, that's going to start presenting in the urine. Type 2 diabetes is usually diagnosed somewhere around 120. So that means that you could technically have diabetes and not have glucose in your urine until you go above 180. Now, unregulated type 2 diabetics can have starting blood glucose levels of above 400. So definitely shows up in the urine. But that's why a blood glucose test is better than a urine test, particularly if you're in that early stage borderline area, because it's not always going to show up in the urine until you're above 180. Now, that is the transport max for glucose. Other solutes would have other concentrations. All right, proximal convoluted tubule is where most of this is happening. We're going to get back about 65% of all of the water, okay, so working on that obligatory return, all of our glucose, all of our amino acids, and the bulk of all of our ions. That's why we've got all those mitochondria. That's why we've got all the microvilli, increasing the surface area for this to happen. In the nephron loop, we go down, and the descending limb is going to be permeable to water but not solutes. The ascending limb is going to be permeable to solutes but not water. So as we go through the limb, we are going to reabsorb both water and solutes, but not together. So water is going to be reabsorbed on the descending side, and then solutes are going to be actively transported out on the ascending side. This water reabsorption is still part of that obligatory return. So this is water that is pretty much always going to come out as we go through the loop. When we get to the distal convoluted tubule, and to some degree, but more the collecting ducts, here's where we begin to vary the amount that we're going to reabsorb based on the needs of the body. This is under hormonal control. So we have several hormones that target the DCT and the collecting duct. Again, collecting duct more so than the DCT, but a little bit in the DCT, that are going to drive specific processes when we have certain things going on in the body. So ADH targets this. When ADH is released, we know that our plasma volume has gone down, or our extracellular fluid has gotten a little salty. So what we want to do is we want to reabsorb more water. ADH directly causes aquaporins to be inserted into the collecting duct membrane, and it's going to allow us to reabsorb more water. The more aquaporins we have, the more water is going to move back into the body. Aldosterone increases the amount of sodium reabsorption here. So it's going to drive sodium reabsorption, which is then going to, of course, drive water reabsorption. Atrial natriuretic peptide, actually all of the natriuretic peptides, inhibit the reabsorption of sodium. So if the sodium stays in the filtrate, so does the water, and that's going to allow us to have a higher volume of urine. Parathyroid hormone increases the reabsorption of calcium and also increases the secretion of phosphates. So when we need to make sure that we have calcium in the body, one of the things that we do is we get rid of the phosphates that it would want to bind to. So we will reabsorb more calcium and secrete more phosphates. So these are all hormones that you've heard of before, and now you can kind of put together where they are going to have their effect. So we've reabsorbed, and now we go into this other process, which is secretion. And in tubular secretion, we are going to move very specific selected substances from the blood into the filtrate. So we're going in the same direction as filtration, but it's highly specific. This is not if you fit, you filter. This is not only specific to individual substances, but also specific as to how much you would secrete. So this gives us very tightly controlled mechanisms, whereas filtration is just you fit, you filter. Okay, so that's why these two mechanisms exist. So first of all, it's going to help us move drugs and metabolites. So the clearance rate of drugs is how quickly we can go through tubular secretion. So the movement of these, making sure that if they are filtered out and then reabsorbed, that they are moved back into the blood. When you have certain drugs that you have to take multiple times a day, it's because of this clearance rate. So you have to take it multiple times to maintain a stable level. This is going to help us get rid of some of our urea and our uric acid. So we have a urea-uric acid cycle, and so it's constantly being pulled out of the nephron loop and then sort of reabsorbed in multiple places and then secreted back out. But again, not all of it. It allows us to secrete a sort of specific amount of the urea and the uric acid, allowing us to hold some of it back for use. So we're going to eliminate any excess potassium ions. So when we begin to secrete aldosterone, we're going to reabsorb sodium. And when we reabsorb sodium, we have to start secreting potassium. So whenever we release aldosterone, potassium secretion starts. You have to start moving potassium out of the blood and into the filtrate. And then our pH homeostasis is going to apply here. This is how we're going to move hydrogen ions and sometimes bicarbonate, but mostly hydrogen ions. We're going to move those hydrogen ions into the filtrate at a very specific rate because we don't want to lose all of our hydrogen. If we do that, we're going to become too alkaline. So we need to remove just enough hydrogen to maintain our pH. So here you can see that you've got multiple areas that are going to go through reabsorption and secretion. So it's not specific. This isn't sequential where, one happens here, one happens there. Secretion and reabsorption happen all along the tubule, and here you can kind of see some of those.